Good afternoon, everybody, and welcome to one more episode of Pandemia series. This is a series that is brought to you as a collaboration between the Latino Commission and the COVID-19 Prevention Network. Today, my name is Roberto Mares. I am the Director of Community Mobilization Programs at the Latino Commission on AIDS, and today I will be your host and your moderator. The topic today is related to what's happening right now in the area of COVID-19. We have been witnessing the presence of a new variant, which is Omicron, and many of us had got infected despite the fact that we got vaccinated. So today the topic is basically talk about Omicron and everything related to it, including treatments for COVID-19, new advances in treatment. For today's presentation, we have two members of the expert committee for the COVID-19 Prevention Network, Dr. Jose Cordero, who is a distinguished professor of public health and chair of the Department of Epidemiology and Biostatistics at the College of Public Health at the University of Georgia. He served for 27 years in the U.S. Public Health Service at the Center for Disease Control and Prevention, CDC, as Assistant Surgeon General of the Public Health Service. He held leadership positions at the CDC focused on improving the health of mothers, children, and adults. Dr. Cordero served as Deputy Director of CDC's National Immunization Program and was the founding director of the National Center at Birth Defects and Development Disabilities. Following his CDC retirement, he was named Dean of the School of Public Health at the University of Puerto Rico. His research has focused on promoting childhood immunization and the eradication of congenital rubella, a virus that causes severe birth defects. In these COVID-19 times, he has served as a consultant to local and territorial health departments to improve prevention efforts through vaccination, open masking, and new therapeutics. And we also have Dr. Edwin de Jesus, who is a graduate from the University of Puerto Rico School of Medicine. He completed internal medicine and infectious disease training at the Medical College of Pennsylvania and became board certified in infectious disease. He is the medical director of the Orlando Immunology Center, specializing in HIV, hepatitis, STIs, and in the management of people at risk for any of those conditions. He became a fellow of the American College of Physicians in 1996 and a fellow for the Infectious Disease Society in 2012. He has faculty appointment at the UCF College of Medicine. Since the mid-90s, he has been involved in antiviral and vaccine research, overseeing hundreds of phase 1 to 4 clinical trials, including working with the NIH, DAIDS, and the CDC. He is also an advisor for the R&D scientists in the creation of new study concepts and has presented several study results at international conferences. Since the advent of SARS-CoV-2 COVID-19, and in collaboration with the NIH COVID-19 Prevention Network and private pharma, he has been actively involved in multiple clinical trials that have led to the approval of COVID-19 preventive vaccines, monoclonal antibodies, and COVID antiviral medication. So today we have this important topic, and Dr. Cordero is going to start us with the presentation. At the end, we will have time for questions and answers. Dr. Cordero, you can share your screen now.
Thank you. I need the permission to be sharing my screen. Okay.
Okay. Yeah, give it to. I'll share for you, and I can pass for you.
Okay. Thank you very much for the opportunity to talk in this session, where we'll talk about COVID-19, but also more specifically about the variants and what's the difference. Let me just sort of remind everyone that COVID-19 is what we call the disease that we see from the coronavirus, that it's known as SARS-CoV-2. And if we could go to the next slides, so I could just start. Okay, so SARS-CoV-2 is a virus that causes COVID. And this is a virus that changes over time, and it's not the only one. There are a number of viruses that actually do change over time. Influenza is one example, and that's why it's so important to get the influenza vaccination on a yearly basis. Most changes that happen in this virus as they replicate, I said are really minor, but there's some that from time to time that may actually be important because they may lead to clinical changes in the disease, making it more severe or perhaps some more transmissible. And so if I could go to the next slide, I'm having trouble. There we go. Changes that are considered clinical include severity of the disease. Like, for example, the disease could be more severe. And in fact, that's something that we saw with Delta variant that we'll be talking about. Other different variants may be easier to spread from person to person, or may have less efficacy, or allow for less efficacy for treatments or for the vaccine, and may lead to something that's called breakthrough infections in vaccinated. That is, the person that's vaccinated may still get the infection, although most of the time it's much less severe than if it was not vaccinated. If we go to the next slide, let's just talk about what the specific variants. There is an organization, part of the World Health Organization, that actually revises all the new data on changes in the viruses like SARS-CoV-2. And there are a number of variants that have been identified. The first, called Alpha, and those letters is following the Greek alphabet. But the Alpha variant was first identified in the United Kingdom, and since then there have been a number more. But we're going to spend time talking about the Delta variant that had been around for a while, and the newer variant, Omicron, that also now is taking over and becoming the most predominant type of variant. Next slide, we'll go into the specifics and about the Delta variant. This is a variant, when it arrived, caused a lot of concern because the disease seen with Delta variant was just much it was greater than in the call it traditional or the Alpha variant. That was one that diffused quite all around the world, and so that was actually a major concern, and it also tended to spread more easily than the original COVID virus. And it also caused some breakthrough of infections. But it had the good thing was it did not have an effect that diminished the efficacy of treatments. Now, in contrast, when we look at what the Omicron variant is, that we'll see in the next slide, this is a virus that is actually a lot more, have less severe disease, fortunately, but it spreads very easy. And the reason is that the Omicron variant not only attaches to the cells in the lung, like what happened with Delta, but also to the cells that are inside the nose and in the throat. So it allows it to grow very fast, grow a lot more virus, and also increases it's more likely to spread the virus to other people. Like with the Delta variant, also we have some breakthrough infections among those that are vaccinated. Another difference is that the Omicron variant actually makes it much harder for certain therapies like to actually be effective, and so that's an important consideration, and it gets us into what do we do to protect ourselves from COVID now based on the Omicron variant. And if what we have are good news. If we go to the next slide, we can see that Omicron variant if the vaccine is very effective against this variant, and it also protects against severe disease and death. Also very, very important. Like many vaccines, the important thing is that we want to protect people, or they do protect people against the disease and also from dying. We do have with the Omicron variant breakthrough infections, meaning that vaccinated people may actually have the infection. And that is one of the reasons that is spreading so quickly, because the vaccinated person may just have a very mild infection, may be asymptomatic, have no symptoms, but still be carrying the virus. And again, that's one reason that it's so important to wear a mask, not only for protect oneself from someone else's spread the virus, but from us if we have it not without knowing it, that we also are protecting other people. The Omicron also have some increased resistance to some of the treatments. Could we go to the next slide? So when we look at what we can do to protect ourselves, it's important to just get vaccinated. And the protection is even better when you have the booster. So if you have gotten your 2 doses and you still need a booster, and you have the time to wait between the 2 doses and the boosters, please go ahead and get vaccinated. It's going to give you much greater protection. But also, it's important to wear the mask. And an article on a study that just was released by CDC this week shows that the masking, whether it's with a cloth mask or whether it's a surgical mask or a K95 respirator, are very effective. But the greatest protection is with a surgical mask or the KN95. So if you have to select, and you can choose surgical mask and K95 if you want to have greater protection, especially if you think you're going to be in a situation where you're together with many other people in an inside location. Next. So to summarize, the Omicron variant is what's being spread right now, and it is a vaccine that is highly effective, and you will be hearing more about the efficacy of this vaccine in the next presentation. And again, just pointing out in the next slide how it's beneficial for masking. So when the study compared those that did not wear a mask in terms of getting infected, a cloth mask actually had 56% better odds of not getting infected, about 66% for the surgical mask, and 83% for the N95 or K95s. So again, the bottom line is, let's get vaccinated and let's wear a mask. Thank you very much.
Thank you very much, Doctor. I'm going to please, everybody, write your questions for Dr. Cordero, and also for Dr. Jesus after the presentation in the questions and answer box, so we can read those questions for the doctors who are presenting. I'm going now to allow Dr. Jesus to stop because he's done. We're having technical difficulties. Just 1 second, please. Yeah, apparently he's logging in again. In the meantime, I want to thank everybody for being here, and good afternoon, good morning, wherever you are in the States. Please write your questions, as I mentioned again, for Dr. Cordero and later for Dr. Jesus, in the question and answer box that is located at the bottom of your screen. This is an important webinar that is brought to you by the collaboration of the COVID-19 Prevention Network, the Latino Commission on AIDS, a series of webinars that we started in 2020 to bring information about COVID-19 and COVID-19 vaccines to the Latino population. While Dr. De Jesus arrives, Dr. Cordero, maybe you can answer this question. Irving Mendoza, he says, yesterday I read about the spread of Omicron in deer populations in New York. What do you think about zoonosis, the power of transmission of the disease between humans and animals, and the generation of new variants that can make the virus more resistant and dangerous? Dr. Cordero?
Yeah, I had a little trouble hearing the entire question, but I understand that it was about the fact that the virus can be transmitted to animals and then the impact that may have in terms of the changes in the virus. Was that the question?
Yes, he's mentioning zoonosis as a factor that can increase the virulence or promotion of the virus.
Yes. Okay. First of all, this virus, of course, the SARS-CoV-2 and basically the entire family of coronaviruses tend to be actually sort of living in different animals like bats and others. And part of the transmission, it is when it goes from, say, one species to another. But also the other part of transmission and what it looks like it's the main reason that we have these variants is just as the virus replicates in the person that is infected. There might be some errors in the way that the DNA is copied, and that's what leads to some of these variants. So it's somewhat of a random, but both mechanisms, just how it replicates in a person, but also how it goes to an animal or actually goes into a new kind of species is another process for replication. And we need to look at coronavirus and the COVID infections not only as a human problem, but it is an One Health problem. We need to also consider what needs to be done in control of this infection in animals throughout the world. Thank you.
Thank you very much, Cordero. Please continue to write your questions in the question and answer or in the chat box. And those who are watching the streaming of this through the page of Facebook of the Commission Names, you can also write your questions in the comments and we will bring it to you. So Dr. De Jesus is here now. Welcome, Dr. Edwin Jesus, and we can continue with the presentation. I will share just your slides if you want.
Could you pass advancing for me?
Yeah, I will do that.
Thank you. So
Yeah.
Great. Well, thanks, Luis. And I am happy to share this episode of Pandemia 11 with Dr. Cordero. We just heard him presenting an overview of the current COVID, especially the Omicron variant, and the measures that we all have to take to prevent the spread of the infection now and in the future. In this section, I will briefly then present you the rationale that have prompted a very fast COVID pharmacological development and to provide you with a brief update of the current pharmacological agents that we have to help us manage COVID-19. Next slide. So, in a month or so from today, we will reach the second anniversary since COVID was declared a pandemic. So, yes, we're going to be entering the year number 3 of COVID. And let's not forget that it only took about 3 months from the first report of the cluster of patients in Wuhan, China, to the declaration of a pandemic by the WHO. So that fast, the virus spread throughout the world. So it's no surprise that our national and our global response needed to also be as fast, just to catch up with the speed that COVID was spreading. In fact, by the time that the WHO declared a COVID pandemic, that same week, the NIH started the first COVID-19 vaccine phase 1 study in the same week that it was declared a pandemic. So how was that possible? It was possible because although these virus and the disease that caused the virus, COVID, were new to everyone, we quickly learned that the virus was a family of the coronavirus, was a part of the family of coronavirus viruses. And this is important because that family of virus has been extremely and extensively studied. And members of the same family shared similar properties. So the rapid pharmacological development of agents to treat and to prevent COVID was possible because, number one, we have a pre-existing familiarity with the family of coronaviruses, because we have huge advances in the development of virology over the past 20 years. We have a lot of technological advances and our ability to deal and to handle genetic material, viral genetic material very rapidly. And our ability to share information from any part of the world to another within seconds. And also, most importantly, perhaps, was the sense of urgency that we had 2 years ago. And that happened at all levels, governmental, scientific, clinical. It was a sense of urgency after realizing that we were confronting a deadly pandemic for which we had no treatment. So all those factors contributed to to expedite the quest and the development of therapeutic agents that hopefully will spread will stop the spread of the infection. And among other responses was the operational warp speed, the federal effort that supported multiple COVID-19 candidates to speed up the development. But since that our initial response was not fast enough, the virus mutate, especially this is a single-stranded virus that have a high mutation rate, because when you say single-stranded RNA, those viruses tend to mutate quite rapidly, and although some RNA viruses can mutate faster than these coronaviruses, we have seen how much problem we have confronted with the evolution of the genetic material in these viruses and the mutations and new variants. So that mutagenicity and the high infectivity rate that the virus have acquired over time is what is causing the problem. And we're only going to be able to combat and to fight that with a massive vaccination program, and hopefully following the CDC recommendations to protect ourselves and yourself, and as Dr. Corderon, Cordero just presented. Next slide. So, can you give me the previous slide? Next slide. So these are the COVID vaccines, and as you already know, we have a few vaccines available for the prevention of the infection, or at least to avoid the progression of COVID. That have been proven to be safe, and we continue to gain more information about the efficacy and safety of those vaccines as we continue to, as time goes by. So what is new with the development of this vaccine? Here we have a slide that specifically talks about the Pfizer BioNTech vaccine. This is an mRNA vaccine. And what is new is that there has been some updates in the approval of that vaccine by the FDA, and some of them by just with emergency use authorization. This is the only vaccine that can be given to children less than 16. It's already approved for that patient population, FDA approved. And it also have some approval for ages 5 to 11. Again, the dose that is used is 10 milligrams, which is a third of the dose that is used in adults. And when we're dealing with a child that is ages 5 to 11, that has significant immunosuppression, perhaps we should consider the addition of a third shot in that population. Is currently undergoing review to be used in patients that are 6 months to 4 years of age. The vaccine has also been approved for as a booster, and again, because it can be given to already FDA approved for ages 12 to and older, it's the only booster that we can use in that pediatric population. And the FDA has granted the heterologous status for boosting, which means that if the person has been boosted, has been vaccinated with any of the currently available vaccines, we can boost that particular person with the Pfizer vaccine. And it should be given at least 5 months after the completion of the primary series, except when the primary series was given with the Janssen vaccine, that then the booster should then be given 2 months, within 2 months. Next slide. The second vaccine is the Moderna vaccine. Was recently, just a couple of weeks ago, granted FDA approval. It's also an mRNA vaccine for primary series. 2 shots are used; they're given 4 weeks apart, and in the dose of that vaccine for primary series is different than the dose for boosting. When it's used for boosting, which is also approved for the ages 18 and older, that either has received the Moderna vaccine or have received any other vaccines, we can use it as long as the person is greater than 18 for boosting. There is also, as in the Pfizer vaccine, the consideration of using 3 shots that are to be given the third shot 4 weeks after the primary series, as part of that primary series, in people that have significant immunosuppression. There is compelling data that booster shot has significantly improved the vaccine efficacy against the Omicron variant. Multiple studies by all these sponsors and multiple agencies have shown that that degree of protection achieved by boosting one of those primary series has the ability to overcome significantly and combat this most resistant strain of Omicron. However, the transient rate of side effects remain the same. We also have compelling evidence that indicates that if we use as a booster the full dose of the vaccine instead of the half dose, there's also an improvement in the level of protection, but that has not been approved by any of the regulatory agencies. A third vaccine that is available in the United States is the Janssen vaccine. That vaccine is available under emergency use approval. It's only one shot as a full dose, 0.5 milligrams as a single dose, and also can be used as a booster, same dose, same vaccine, and should be given 2 months after the primary series. It also has the indication for heterologous indication under the EUA, and if a patient was vaccinated with any of the other vaccines, they can use this as a booster, although that appears to be a less likely scenario. We need to keep in mind that there's some contraindications that are being followed very closely with the use of this vaccine, such as thrombosis and thrombocytopenia that has been related, especially if the person received the primary vaccination with Janssen and developed any of these complications. This patient should not be given a booster with the same vaccine. It is believed that these potential complications are the cause of are being caused by the adenovirus vector part of the vaccine. There's also some warnings about the thrombosis and thrombocytopenia that can occur with this vaccine, and there's a registry monitoring those conditions. The next vaccines that we have available, if you can you give me the next slide, please? The next slide is the Seneca Oxford vaccine. That vaccine is not available in the United States. It has not received EUA approval or FDA approval. There's many issues that have been found, not only with some potential adverse event, but with the manufacturing quality, and the FDA is looking into that. However, it has been approved in over 170 countries throughout the world, so it's widely used in other continents, and it's used as a 2 shots, each of 30 milligrams, given 3 to 6 weeks apart, and as a boosting for children, for people above 18 years of age. So again, we can use, or in countries where this vaccine is approved, they're using it for boosting, also with a heterologous indication. There's some evidence that using a 3-dose of the AstraZeneca vaccine, at least in Europe, has been very effective against the Omicron coronavirus variant. There's also a warning about thrombosis with thrombocytopenia for the same reason that is happening with the Janssen vaccine, because it's a viral vector recombinant vaccine with an adenovirus, and there's an association with the risk of thrombosis and thrombocytopenia. Next slide. So we have other COVID vaccines. In fact, Delta vaccines has been approved all over the world, and even in the UK, there's 6 COVID vaccines currently in use in the United Kingdom. There is over 100 other COVID vaccines that are currently under development and in active study, and some of them are more ahead than others, but there are significant advantages that we can see with some of these vaccines in terms of potential less toxicity and potential more durable and robust immunologic response. Next slide. So there's other therapeutic advantages that we have. In addition to vaccine, we have treatment options, preventive options to manage COVID. These agents could protect people that are at high risk of acquiring infection if they acquire the infection when some of those agents are given even pre or post-infection, they can prevent the person infected to progress and to have bad outcomes. In addition, people that acquire infection and become acutely ill can also prevent them from worsening and further deterioration. So it's important that we keep these other agents on mind. And here in these slides, we have the use of monoclonal antibodies. They have received EUA from the FDA for the treatment of non-hospitalized patients with mild to moderate COVID-19 who are at risk of progressing to severe disease. In the United States, we used to use the three of those, the three combination of monoclonal antibodies that we have there, but with the since the onset of the Omicron variant, the monoclonal antibody number 2 and number 3 combinations has been deemed not to be protective against the Omicron variant, and only the sotorumab at a dose of 500 milligrams, is an infusion, of course, can be used for children at the age of 12 if they weigh more than 40 kilograms, and it needs to be given started within 10 days from the onset of symptoms. These infusion can cause some infusion-related problems, such as hypersensitivity reaction and anaphylaxis. So these type of medication need to be administered in a facility that can handle that type of acute complications. And we need to monitor the patients that they're infused, and 1 hour after the infusion is completed. Again, the other monoclonal antibody combinations have reduced susceptibility against the Omicron variant. Next slide. And then we have the antiviral agent. And in the antiviral agents, we have Paxlovid. Paxlovid is a combination or a package formulation of a protease inhibitor that is orally viable and can be boosted with the use of ritonavir. These medication inhibit the embryo, the viral protease, that plays an essential role in viral replication. It has demonstrated activity against all coronaviruses that are known to infect humans, and is packaged with ritonavir for boosting, which is a strong cytochrome P450 348 inhibitor. And with that, we know that there's a lot of drug-drug interactions that can occur. This medication is dosed 300 milligrams with 100 milligrams of ritonavir. And again, the combination of those is what is called Paxlovid. And it's given twice per day for 5 days to any person greater than 12, equal or greater than 12 years of age, weighing more than 40 kilograms. A second medication that we have actually was approved earlier by the FDA, not only in hospitalized patients with moderate to severe disease, but for non-hospitalized patients with mild to moderate COVID-19 who are at risk for disease progression. And these are not AUA approval, this is a formal FDA approval. And in this type of non-hospitalized patient with mild to moderate disease, remdesivir has been found to have an 87% reduction in the risk of hospitalization and death when they compare that to placebo. And fortunately also has retained activity against the Omicron variant. Remdesivir is dosed at a 200 milligrams IV infusion in the first day and 100 milligrams in day 2 and 3. And it can be given to a person 12 years of age or older, again, 40 kilograms or higher, within 7 days of the onset of symptoms. Like we saw mentioned before, this type of medication can cause significant hypersensitivity reactions and anaphylaxis. So we need to monitor the patient during the infusion for 1 hour post-infusion, and this medication needs to be given in a facility that can handle this type of medical emergencies. It is also approved for hospitalized patients, especially they require oxygen. That is also another indication for hospitalization from COVID, in which case they strongly recommend the co-administration of dexamethasone when possible. And the last antiviral that I'm going to discuss is molnupiravir. It's an oral prodrug that is a ribonucleoside that inhibits the RNA-dependent RNA polymerase in the virus. So these enzymes, the RNA-dependent RNA polymerase, what it does, it causes then a lethal mutation in the virus. And because that occurs, there's a theoretical risk that this drug could be metabolized by human host cells and incorporated into the host DNA. But multiple studies have shown that for that to happen, probably need to be given over a prolonged period of time, and because the drug is only administered at a lower dose and for 5 days, the FDA deemed that was approved, that was safe to be approved for the management of patients that we could not manage any other way. So if a patient is not a candidate for Paxlovid or any remdesivir or any of the other approved medication, then we can consider the use of this agent. It is also active against the Omicron variant. Next slide. So I guess that this led us to what is going to happen next. In the US, there's a significant reduction in the COVID incidence over the past few weeks, but the incidence overall remains fairly high. In fact, it remains in the average as high as the first spike the first surge of COVID in our nation over a year ago. So the incidence remains. The incident rate remains too high, despite that they're decreasing, and they have not been followed by a reduction in the incidence of COVID worldwide. So this is just happening overall in here, but not everywhere. Another problem is that in all places in the United States and all over the world, there's clusters, significant areas where the incidence of the infection is significantly high. So the decrease only appears to occur sporadically in some places and not the other. And the same can be said in the United States, where if you look at the incidence by state, we see that in some they're going down and in others they're going up. And the cluster of people that are getting infected because perhaps they're not vaccinated represent a problem. When we look at the uptake of vaccination, we see a resemblance of that, where in places where we have a high uptake of vaccination, we see now a lower rate of infection. We still have a significant amount of people in the US and more so worldwide without any degree of active, recent, or past immunity. In the United States, 65% of the population has been vaccinated, and much less than that have been vaccinated worldwide, where it is believed that less than 50% or around 50% of the population worldwide has been vaccinated. So 1/3 of the population in the US is vaccinated, and half of the population worldwide is a lot of people to be unvaccinated. And unvaccinated people, as I said, tend to be clustered, and vaccinated people that have not been exposed to the infection tend not to have, of course, any antibody protection, any immunity against COVID. So when the infections occur, a person that has no immunity behave different than a person that have some degree of active immunity, even if the active immunity occurred in the past. So with active immunity, either because the person suffered the infection and create the own natural antibody, or because it was induced by a vaccine, all those antibody protection eventually wears off, but there's a residual amount of antibody protection that make those patients behave different than a person that has never suffered the infection or received the vaccine. Those patients that are unvaccinated and that do not have experience or have been infected before with COVID, they're like a free canvas where the virus go and can replicate freely. And with viral replication and uncontrolled viral replication, that's when the potential for mutagenesis in this virus can be greater. So for people that have some degree of immunity, even if the immunity is not enough to prevent them to get reinfected, even if they get reinfected, they don't develop the levels of viremia and they don't shed the virus, and they as high or as much as unvaccinated people, and they are less likely to be the source of other infections in close contacts. So in order to prevent these to happen and to get a better control over the next year or so, a more comprehensive and robust preventive strategy would need to take place in order to prevent what we're seeing today. So with that, I will stop and I will take any questions.
Yes, thank you very much, Dr. Jesus and Dr. Cordero, for your presentations. We have questions here. Somebody asked, can a person recovering from COVID-19 needs a booster if she received monoclonal antibodies? Any one of you can answer.
Yeah, so a person that has COVID acutely should not get the vaccine right away. We need to, it's better if we let the infection and the body to pass the acute stage of the infection, and a few weeks after this happens, then the person can get vaccinated. But what we are seeing is that a person that gets infected develops some antibody protection that is about equal what we expect them to develop if they get a vaccine. The problem is that they don't last as long. So some people may develop, have natural infection and may develop antibodies, and the antibody may last longer because they're response with the immune system. And other people, their antibody protection that they developed didn't protect them enough. That has also something to do with the variant that they get infected. And the good news is that if we combine the antibody that the person produced with the one that the vaccine produced, they don't contradict each other. They actually have an additive effect. So that person that has the infection and later get immunized, or the other way around, is probably likely more protected.
Thank you. Dr. Cordero, you mentioned in your presentation the importance of masking, how masking has had an impact in reducing the number of cases for COVID-19. But what we see in the States, for example, in New York, is that the mandate of using masks is being lifted. So what do you think about that?
Sorry, I was muted. Masking is this is a very important question, and we need to separate what the science teaches and what the science tell us. And my presentation, I just summarize the efficacy of the different kinds of masking. And at this time that we have a variant like Omicron that spreads very easily between people. Number two, that even vaccinated could be asymptomatic and be transmitting the virus. Wearing masks is really very, very important. And we need to separate, what are maybe the beliefs from what actually is the reality. And right now, if we want to be sure that we can slow down the spread of this virus, it is taking the vaccine, getting the boosters, and wear the mask. It is going to be the combination that we'll need to follow while we have the Omicron around us.
We want to talk, Doctor, what do you think about combining different kinds of vaccines? For example, Moderna first and the second dose is the Pfizer and the booster. And that was a question from Karina Escamilla.
So, large form of study has not been conducted. Mainly the data that we have has been collected observational data because patient got the vaccinated, the primary series with one and then they got the booster with the other one, or sometimes they got one shot with one and the second with the other one, which was not even a consideration back then. However, what we have seen is that so far, when mRNA vaccines are combined, the response appears to be equal as if one of those vaccines was given instead of using two different vaccines. So there's no harm by either completing or the series with one of those mRNA vaccines. We don't have enough data to talk about the combination of a vector vaccine and an mRNA vaccine, but observational data have also suggested that there's no problem, and with the because we have not seen anything negative. In the case the Janssen vaccine was given authorization to be used for a booster for heterologous conditions where the person got primary series with one vaccine, mRNA, and can use a booster or vice versa.
If I could add, I got my first two doses was Pfizer, and the third I had the Moderna. And the reason is that was what is available. And so something to keep in mind is that if you have to choose between getting vaccinated with, say, if you have Pfizer and then Moderna and then Pfizer or Johnson, the important thing is that the sooner you get vaccinated, the better. And that may be the important message here. Don't wait. You need to get vaccinated. Do it what you can.
And the other question, like people have been vaccinated and received booster and they seem like infected. What can you say about that? Like I got another COVID-19 after receiving the two doses and my booster.
Read your microphone is.
Is it now better? No. No?
Yeah.
Okay,
good.
Perfect. I'm sorry for that. I was saying, like, what can you tell to people that have been vaccinated or received the booster and still get infected? I, for example, was diagnosed with COVID-19 on January 8th, and I have received my 2 doses of my booster. Although my case was very mild and it did almost no symptoms at all. What can you say about that?
So what would I tell a person that already said
or anybody who's saying that it doesn't matter if you get vaccinated or not because you're going to get it anyway.
Oh, so that's not a good idea because we don't want. In one way, yes, if the person get the infection, they're likely going to get some immune protection if they survive and they don't have any major complications. But why to take that chance? First of all, a person that is vaccinated that get the infection, they can infect other people more rapidly, and they can have a bad outcome themselves. So I would say no, get vaccinated and prevent the infection with the vaccine, or if the vaccine is not able to prevent the infection, at least the vaccine is able to prevent a significant progressive disease. Those patients that are vaccinated, even when they get infected, as I said before, they don't develop the overwhelming viral replication that is the one that eventually causes a problem and causes progression and causes more transmission to others. Mm-hmm. So vaccination, boosting and keeping that immunity at a good level is the key.
What about those for children that are younger than 5 years? Is there anything, any progress in these studies? Dr. Cordero, can you tell us?
Younger than 5 years?
Yeah. Younger than 5 years.
Okay. Do you want to go ahead, Dr. De Jesus, and I'll follow?
Yeah. So there's the Pfizer vaccine is being currently under review by the FDA. Initially, I guess with for an EUA approval, EUA authorization, which is for children 6 months of age to 4 years of age. Because in 5 years already they have the approval, the temporary approval. But younger than 5 years, then up to 6 months, this approval is pending review of the data. And they're using, I think there is like about a third of the dose in the adults, 10 milligrams.
Yeah, if I could add, I agree. It looks like Moderna also is doing some clinical trials, and it's likely that the Pfizer vaccine, the 6 months to and up, would be approved soon, even if it's just under emergency authorization. But I think that it just reminds us that when we are getting vaccinated, especially when we were talking about the last question about what happened if I still can get the infection. But the important thing is that there are people that cannot get vaccinated. The children is the one example. There are others because of certain conditions are not unable to get the vaccine. So that's why people around them need to be vaccinated. And especially if you have children, getting vaccinated is the best way that you can protect them if they are on an age that they still cannot receive the vaccine.
Thank you. Dr. Jesus, you mentioned different vaccines all over the world. Did you mention the Chinese, I think Sinopharm, and the Russian Sputnik that have been used a lot in Latin American countries? What do you think about those vaccines?
So the problem is, I don't know about the Chinese vaccine, but the Russian vaccine, we don't have the raw data. So for us to either recommend a person that receives the vaccine to have a booster or to make any like a heterologous combination that we're doing with the vaccine in which we have data, it's easier for the regulatory agencies to make a formal recommendations. But I personally, and I believe that the FDA will do the same, will be hesitant to make a formal recommendation for somebody that received any of those vaccines. And I don't know if Jose have more information about it, but the problem is that data has not been made widely available.
Yeah, I think that the important, just to point out that some people that actually are a little bit hesitant on getting vaccinated with one of the vaccines that are already approved by FDA. Those vaccines actually followed a very, very comprehensive process of clinical trials. And actually the number of individuals that were tested is just the same that's done for all the other vaccines that actually have been approved and that currently are in use. And the difference with the Sputnik and the China, the vaccine from China, is that we don't have information about their efficacy, especially the Sputnik began to be administered before the clinical trials were actually completed. So very little data on their efficacy on those two vaccines.
There's a question from Suzette. She says, any signs for breast milk and COVID? I know a lot of cases that the mother is COVID positive and the baby continue being negative. Any comment on that?
I think that the question comes down to, should you breastfeed if you are COVID positive? Yeah. And the overall recommendation, the American Academy of Pediatrics right now, is that it would be better that you express your milk and then and it's mainly because of the direct contact. But basically during just the period that you're still positive, but then you should continue to breastfeed.
Angel Colon asks, how long after coming down with COVID can a person get their booster?
So between primary vaccination series and the boost, they go booster, they go to
I was saying that the person that having already received 2 vaccines, right? And so he's waiting for his booster, and then suddenly he presents COVID. So how long after COVID he can take his booster?
So we answered this kind of before. The question is, what to be vaccinate a person that have active COVID, and this relate now not to primary series, so the person already have the primary infection. The person is ready for the booster, but they get COVID. So hopefully likely that person will do well because they already have primary vaccination, so they already have some degree of protection. But they should wait until the course of the infection has subsided. And I believe that 2 to 4 weeks later, the person can get vaccinated with a booster.
Okay, so Mercedes asks, can a person who received monoclonal antibodies after his second COVID infection still need a booster shot? And the person has received Johnson & Johnson vaccine.
Yeah, so any type of process that causes the immune system of the body to have antibody against COVID is going to be good, with the exception of getting the infection, which is if you develop antibodies, it's a great thing, but you cannot just ignore the other ones. So a person that received passive immunization, and by passive immunization means that already monoclonal antibodies that were produced outside the body are infused into the person. So the person is not creating them themselves. They don't last long at all. So a person that gets vaccinated and then eventually get a monoclonal antibody because they were exposed or because they have significant risk factors and they get this monoclonal antibody, they still should proceed with the booster vaccine, because the monoclonal antibodies, they don't last long in the body.
I think we have more question about monoclonal antibodies are products of blood, right? So what about people living with HIV or hepatitis that are infected with COVID and then the cure? Can they donate for monoclonal antibodies or for that?
Okay. Can you repeat the question? It said if someone who has HIV is vaccinated, whether they should receive monoclonal antibodies?
No, if the person has HIV and he gets infected with COVID-19 and they recover, okay, can he be a part of the people that they get monoclonal antibodies from? No?
Okay, the main indication for getting monoclonal antibodies is in the very initial symptomatic part of the infection. So if the person, whether has HIV or not, starts and it appears to have a clinical course that it's fairly becoming or starting to be severe, like requiring oxygens, being in the hospital, etc. It's a candidate for monoclonal antibodies, whether it's HIV or not. Dr. Jesus, I think that
I don't
may want to add.
that the treatment or the management of that patient should be any different. The only thing that we need to take in consideration is because the patient, that particular person has HIV, he has another risk factor that can contribute to more disease progression, and we need to be a little bit more aggressive in treating that particular person. So we should probably not wait until the patient requires oxygen. We should probably not wait until the patient is too sick, because they already have a couple of hits under the belt. I mean, HIV infection comes in a lot of variety, from people that have very high T cell count and they never had a low T cell count and they're virologically suppressed, up to people that really have very low nadir T cell count and maybe they're still have they don't have virologic suppression. So we need to manage those people in a kind of individualized way.
Right. Yeah, I think that maybe we should clarify and say, if someone has HIV, gets positive, that's someone that should go and probably get the monoclonal antibodies. That would be a simpler way of describing it.
Okay. Well, it's 3:12. We have gone a little bit time that we allocated for this webinar, but thank you very much, Dr. Jesus and Dr. Cordero, and thank you everybody who joined us today for this webinar, and the questions were incredible. We'll see you again next month with episode 12 of Pandemia. We will promote it in next weeks. Thank you very much, Dr. Jesus, Dr. Cordero, for being here with us.
Thank you.